This conference will now be recorded.
Hello everyone, a warm welcome to our MFDS Part 1 lecture session. By CM Dental Academy. It's an online dental education platform in the field of dental surgery. We aim at delivering excellent quality online training programs and courses for dental students under the guidance of eminent mentors. The subjects will be covered in all the formats such as live lectures, descriptive notes, MCQs, and viva voce questions. So, what are you waiting for? Come, let's begin a journey towards success. So, today's class, in periodontology, we are going to deal with principles of treatment, non-surgical treatment for plaque control, in non-surgical periodontal therapy, scaling and root surface debridement, treatment with antimicrobials, periodontal surgery principles, types of surgeries, regenerative techniques, and mucogingival surgery, furcation involvement, occlusion and splinting, peri-implant mucositis and peri-implantitis, and supportive periodontal therapy. Principles of periodontal treatment or therapy. These are broadly categorized into the initial phase, which is cause related, and the corrective phase and supportive phase. In the initial phase, aim is to control plaque and address modifiable risk factors, such as if patient has a habit of smoking, we have to explain the consequences of smoking and asking to stop the habit. Lies with general medical practitioner if poorly controlled diabetes is there. Periodontal disease is an infection due to the presence of plaque biofilm mainly. Therefore, the disruption of this plaque biofilm and control of plaque is the main key to success. More complex treatment will always fail in the absence of effective plaque control. When patient fails to control this biofilm formation or the plaque formation, even the complex or the advanced treatment modalities will also fail. It includes recording of the baseline indices to begin with. We have to record the baseline indices, which we have discussed in our previous lecture. Thorough oral hygiene instructions to the patients, followed by scaling and root surface debridement, elimination of plaque retention factors, any overhang restorations or any sites which will retain the plaque. Response is monitored for over a period of 8 to 12 weeks after the treatment and further plan is followed. If successful, it can move to the supportive phase. If residual disease, then it will move to the next phase, that is corrective phase. If the lesion or any abnormality will exist, it will revert back to its original phase in initial phase. If not, during this follow-up period, then it will further progress to the corrective phase. In the corrective phase, various treatment modalities are followed, such as to restore the function and where relevant aesthetics. Corrective techniques include non-surgical therapy such as periodontal access surgery, regenerative surgery, mucogingival surgery, resective surgery such as gingivectomy, use of local and systemic antibiotics along with these treatments, treatment of furcation lesions and restorative work, endodontics and occlusal adjustments are required. The main aim of this phase is to eliminate pathological periodontal pockets or to create a tight epithelial attachment where the pocket once existed. Arrest loss of and in some cases improve the alveolar bone support, create an oral environment which is relatively simple for the patient to keep plaque free. While in supportive phase, it aims to reinforce a patient's motivation so that their oral hygiene measures to prevent recurrence of the disease. This phase is receiving increased attention due to the relative ease with which a disease activity can be monitored, such as by probing and chairside diagnostic assays. So these being the three main principles of the treatment, I would like to revise the initial phase, or it is called as the treating the cause mainly, and the corrective phase, mainly treating or reverting back the functional demands of the tissue. Then in the supportive phase. Now we'll switch to non-surgical treatment of the plaque control. The key to prevention is regular and thorough plaque removal. Therefore, oral hygiene instructions are must to the patient. It aims to maintain a dental biofilms at a level which is compatible with the health. Even if it exists, the dental biofilm, it should be in a healthy condition to the surrounding tissues. Means it should not harm the surrounding tissues, or it should not cause any changes to it, so that the beneficial properties of resident microflora, the existing oral microflora, are increased, which are in favor of health, and the risk of dental disease is minimized, such as smoking and any uncontrolled diabetes will exacerbate the periodontal disease, and even further they leads to affects the outcome of the disease. So patient should be advised about this. What are the oral hygiene instructions to be given to the patient to control the plaque, or mainly the biofilm formation? An explanation of the nature of patient's disease. First, patient should be aware what exactly is the disease, or what condition is affecting him in the oral cavity. What is his problem? Once he is able to identify what is happening or what abnormality is happening, he will be able to take care of himself. Like, the conditions will appear such as swollen gingiva. It may show a bleeding on probing. Clinicians should explain to the patient using a hand mirror and then demonstrate the cause, that is the plaque, either directly by scraping it off a deposit or by using the disclosing agent, which will be very easier or convenient for the patient. Using a disclosing solution, explain how plaque starts to grow immediately even after toothbrushing. Then demonstrate how to remove it. Once patient is aware what is plaque or what is biofilm formation, then we have to teach the patient to how to remove it. Avoid over criticism of the patient's present efforts, as this is often counterproductive. These are the points which you have to take into consideration while dealing with the patient. In this phase, scaling can also be performed. Once oral hygiene instructions fail to take a proper care, like prevent the biofilm formation, then mechanical plaque control measures have to be introduced. Though patients will be practicing regularly, but more stress should be given on further requirements. Toothbrushing, it requires a brush, ideally with a small head, nylon bristles, which are about 3 to 4 tufts across by 10 to 12 lengthways, which should be renewed at least monthly. Numerous methods can be described based on the movement of the brush. Most of the patient fails to follow a proper brushing technique, so they should be educated regarding the brushing methods, such as rolling, vibratory, circular, vertical, and horizontal. The best is the one which works for the patient. Patient should be comfortable without traumatizing the gingiva is the main aim to educate the patient regarding brushing habits. Modifications to toothbrush and brushing techniques are also available, especially for the children, elderly patients, and those with disabling diseases. Oscillating, rotating power toothbrushes are also effective. Toothpaste makes the process more pleasant and is a useful medium for topical fluoride and other agents. Anticalculus pastes are also available. They decreases the plaque formation by about 50%. Chlorhexidine containing toothpaste are active against plaque microorganisms. Interdental cleaning. The mechanical cleaning such as brushing will not take care of the interdental papilla. So some special measures have to be introduced to the patients to keep interdental gingiva in a healthy condition. In Europe, the European Federation of Periodontology workshop in November 2014 focused on the best methods of interdental cleaning to reduce gingivitis and plaque levels between teeth when used in addition to mechanical toothbrushing. The work, excuse me, the workshop concluded that cleaning between the teeth on a daily basis is essential to maintain gum health. Flossing, mini interdental brushes, particularly good for concave root surfaces, and interspace brushes were introduced for interdental cleaning. These are all the mechanical measures. In 2014, European workshop also concluded that there is reduced efficacy even after using flossing in removing the plaque between the teeth. And this is mainly because patient finds flossing very difficult to perform and they end up performing it incorrectly. In that respect, interdental brushes are most efficient in removing interdental plaque if there is space to accommodate them. These brushes are the method of choice for interdental cleaning where spaces between teeth allow their insertion without causing trauma. So in such cases, for plaque removal, interdental brushes are the recommended choice. After this, the chemical plaque control. Once mechanical ones fail to take adequate care of the oral gingiva or they fail to revert it back to the healthy phase, then chemical plaque control measures have to be introduced, such as mouthwashes. It helps the patients to, when patient struggles with the mechanical methods, they because of lack of dexterity, disability, or due to mucosal conditions such as aptus ulcer or benign mucous membrane pemphigoid, where the mucosal health condition is compromised. The antiseptic of greatest proven anti-plaque or anti-gingivitis value is chlorhexidine gluconate. It is commonly used in 0.2% in mouthwash or gel form, although 0.12% mouthwashes are also available. A standard regime is 10 ml solution rinsed for about 1 minute for twice a day, or 15 ml solution of 0.12% for 30 seconds twice a day. It can be used instead of toothpaste. But the disadvantage of using this mouthwash or mouth rinse being it causes staining and altered taste. An interaction between conventional toothpaste and chlorhexidine reduces antiseptic's efficacy. Other proprietary antiseptic rinses have yet to meet this gold standard. It is also important to note that in patients who do have good manual dexterity for mechanical cleaning, mouthwashes have a limited adjunctive effect. So in such patients, it is always advisable to carry out with the mechanical measures only rather than shifting to the chemical measures or use of a mouth rinse. Non-surgical periodontal therapy such as scaling and root surface debridement. It consists of scaling, root surface debridement, restorative treatment to correct coexisting or exacerbating factors such as perioapical infection, overhanging margins, and the possible use of adjunctive antibiotics in very specific cases. The aim is to remove supra and subgingival plaque and calculus deposits and local plaque retention factors. Scaling is the removal of plaque and calculus from the root surfaces with the hand instruments such as sickles, curates, and hose. For mechanical removal being using the cavitron. Scaling can be supra or subgingival depending on the location. The supragingival scaling is always a first part of the initial therapy. Local anesthesia is not necessary for this. It is often done together with oral hygiene instructions. Root surface instrumentation, likely requires local anesthesia and involves the removal of subgingival root deposits. It is no longer considered necessary to remove endotoxin-loaded cementum. It is weakly bound and easily removed by scalers. Some clinicians simply use ultrasonics for removal of subgingival deposits. The precise use of hand instruments is largely a matter of personal preference. Like larger curettes are commonly used, however, it is essential to use controlled force and secure the finger rest. It is very important. Unless you're not comfortable and used to with the larger instruments, end up traumatizing the gingiva or the surrounding soft tissues and fail to get the adequate results. Hand instruments must be sharp. Ultrasonic instruments are quicker, but they can be uncomfortable and leave an uneven root surface. They can generate a contaminated aerosol. They employ a frequency of 25,000 to 40,000 cycles per second. Traditionally, one quadrant at a time is treated under local anesthesia, partly because it is painful and partly because it is tedious when performed meticulously. It has been suggested, however, that a full mouth approach is preferable. This means completion of root debridement within 24 hours with concurrent use of chlorhexidine mouthwash. The aim is to reduce the bacterial load and minimize chance of reinfection by reducing bacterial load in pockets and intraoral niches. Treatment and antimicrobials. There are few reasons to use antimicrobials in periodontal therapy. The plaque biofilm affects the response. Concentration in gingival clavicular fluid is low. I'm sorry. Antibiotics have side effects and there is the growing problem with the antibiotic resistance. They are not really justified for use in chronic periodontitis. There are, however, a few indications for the use of systemic and local antimicrobials. Use of systemic antimicrobials in case of periodontal abscess. Initial treatment being the drainage either by subgingival debridement or by incision. If there is any systemic involvement, then antimicrobials recommended are amoxicillin or metronidazole. In conditions such as necrotizing periodontal diseases, which are caused by the fusospirochetal anaerobes, management involves removal of the risk factors such as poor oral hygiene, then smoking first they need attention, and use of metronidazole 200 milligram thrice a day for 3 days in combination with non-surgical debridement. In case of aggressive periodontitis, antimicrobials can be used in combination with conventional subgingival debridement. The recommended antibiotic is amoxicillin with 500 milligrams thrice a day. Metronidazole 400 milligrams thrice a day are used in combination for 7 to 10 days, starting on the first day of the treatment. In case of chronic periodontitis, tetracycline is an adjunct. These decreases host and neutrophil collagenesis and decreases bone loss. Clavicular fluid concentrations are high. Collagenex Pharmaceuticals Periostat, which contains doxycycline 20 milligram twice a day for 3 months is recommended. Makes use of these non-antibiotic properties mainly to reduce collagenolytic metalloproteinases, which prevents the breakdown of the collagen. Local delivery of medicaments. due to controversy over the efficacy and unwanted effects of systemic antibiotics. When for the particular treatment such as in case of chronic periodontitis, patient takes medications orally, the absorption and the distribution of the medicine to reach the target site takes a longer duration. Even the effectiveness of the medicine also or a drug also decreases. So the local drug delivery always becomes advantageous in its effect. These have included using injected paste or gels or by impregnated fibers. These give high local dose, low systemic uptake, and prolonged exposure of the pathogens to the drug. This is being the advantage of the local drug medicaments. The rate of clavicular fluid turnover is such that the substantivity of these agents is low. So where all these indicated? In case of chronic periodontitis, where isolated, recurrent or residual pockets which are of more than 5 millimeter persist even after the conventional treatment and good plaque control measures. In case of root debridement, must be carried out prior to the placement to disrupt the biofilm. That is, before delivering the local drugs into the pockets, a thorough root debridement, that is the cause, should be removed. They may be used if surgery is not appropriate, like in case of severe systemic illness where planning for a surgery becomes compromised. In such cases, local drug delivery system can be used. They are not indicated in case of aggressive periodontitis. Outcome: only small increase in attachment levels have been reported. Various studies for various drugs were performed and are under trial also, but they have concluded that only a small increase in attachment levels. Examples: Blackwell's dentomycin, he used minocycline gel; Colgate-Palmolive Alizole, which contains metronidazole gel; Atrix Laboratories contains doxycycline hyclate gel; and Periochip, which has a chlorhexidine. These are the few very recommended and commonly used for the local drug delivery. Photodynamic disinfection systems have also been developed. These combine non-thermal laser light with a photosensitizing solution used against a periodontal pathogens remaining after conventional instrumentation. So, periodontal surgery principles. Non-surgical root surface instrumentation can be very effective, and there is no absolute maximum depth of pocket where it is ineffective. It is less effective in pockets deeper than 6 millimeter. Non-surgical treatment should always be carried out first before planning for the surgery. Always non-surgical treatment modalities, which we have discussed in previous slides, like oral hygiene instructions, then chemical measures, mechanical measures, when they fail to reach the adequate requirement, then always a surgical approach is planned, as evidenced by bleeding, loss of attachment, or suppuration. Applications of the periodontal surgery: it provides access for the root surface instrumentation. Direct vision of the root surface is possible, particularly helpful in treating furcation defects. Results in a site which is accessible for cleaning. Correction of gingival overgrowth by gingivectomy. Create new periodontal attachment in case of regenerative procedures. Improved aesthetics and function following gingival recession by root coverage techniques. Contraindicated in case of poorly plaque controlled patients and with systemic diseases such as uncontrolled diabetes, severe cardiovascular problems, bleeding disorders. Liaise with general medical practitioner and specialists. Smoking decreases the outcome of the treatment, and some periodontists have limited treatment in those continuing with the smoking. They don't plan for the periodontal surgeries in patients who have compromised control over smoking. While periodontal surgery hardly has a public impact of cardiac surgery, and ethical problem is the same. Teeth with poor long-term prognosis, there also it is ineffective. Choice of surgical procedure. It is dependent on the desired outcome and whether the aim is to reduce the pocket or to eliminate the pocket or to generate the lost attachment or to cover the root surfaces affected by gingival recession or to lengthen the crown for restorative or aesthetic reasons. So the choice of surgical procedure depends on these all the factors. Based on this, what is the main aim of the surgery, or that what is the target of the surgery? Based on that, the surgery will be planned accordingly. General principles. In case of local anesthesia, the infiltration, block, and or lingual or palatal injections are given required. This will depend on the site on which the surgery is going to be performed. Both local anesthesia and hemostasis are improved by injecting directly into the gingival margin and interdental papilla until blanching is seen. This is very important. Then flaps. Some procedures involves raising flap. These should be large enough to provide good access and clear vision. And most flaps are full thickness. That is lifting all the soft tissues off the underlying bone. Some techniques involve the split thickness flap, where the mucoperiosteum remains on the bone. The suturing techniques. Interrupted interproximal sutures are used when buccal and lingual flaps are being reopposed at same level. When flaps are repositioned at different level, a suspensory suture is used where the suture only passes through the buccal flap and is suspended around the cervical margins of the teeth. The periodontal packs after the surgery is performed and the required procedures are being performed on a tooth and surrounding tissues like periodontal flap. Once it is raised, then it is sutured back, and to promote the rapid healing and prevent any abnormalities or any microbial attack on the site of surgery, the periodontal packs are applied or given. These are essential after gingivectomy to decrease post-operative discomfort. May favor them after all periodontal surgery to help reoppose the flap to the bone. So these are classified as eugenol dressings and non-eugenol dressings. Eugenol dressings are usually nothing but zinc oxide eugenol, have advantage of being mildly analgesic, so it will reduce the post-operative pain also, but can cause sensitivity reactions. This is being the disadvantage. Eugenol free dressings such as Coepack, it is become more popular. Periodontal surgery types. Which are the types of the surgeries? The modified Widman flap, the technique which enables open debridement of the root surface with a minimal amount of trauma. Excuse me. There is no attempt to excise the pocket. Although a superficial collar of tissue is removed in this, advantage of this procedure is allowing the close adaptation of the soft tissues to the root surface with minimal trauma and exposure of the underlying bone and the connective tissue. In this, a scalloped incision is made parallel to the long axis of the teeth involved 1 millimeter away from the clavicular margin. You can see in a picture 1 here, a scalloped incision is made away from the gingival clavicular margin 1 millimeter away. This incision is extended interproximally as far as possible, separating the pocket epithelium from the flap to be raised, and then extended mesially and distally. So it is extended interproximally also, allowing the flap to be raised as an envelope without relieving the incisions. The flap should be as conservative as possible and only a few millimeters of alveolar bone exposed by a second incision interclavicularly to release the collar of the pocket epithelium and granulation tissue. A third incision at 90° to the tooth surface separates the pocket epithelium, and this is removed along with accompanying granulation tissue with the curettes and the holes. So here you can see the conservative flap. You have to conserve only the required portion of the soft tissue should be covered. So here excision of the supraalveolar pocket is being performed with the scalpel blade. The flaps are then repositioned close to the original position to cover all the exposed alveolar bone and sutured into the position. So in this picture number 4, you can see here the flap is sutured back to its original position. Post-operatively, once this procedure is performed, patient is prescribed with chlorhexidine mouthwash 0.2% of 10 ml rinse twice a day is given. As healing occurs, pocket reduction is achieved by long junctional epithelial attachment to the root surface. Apically repositioned flap. This procedure is used to expose alveolar bone and includes the option for osseous surgery to correct infrabony defects, allows excellent access to the root surface for debridement. Principal difference between this procedure and the modified Widman flap is the deliberate exposure of alveolar bone and apical repositioning of the flap with post-operative exposure of root surfaces. This is primarily a buccal procedure, and although it can be performed on lingual pockets as well, obviously impossible on palate where a conventional or reverse bevel gingivectomy approach has to be used. So remember these differences between modified Widman flap and apically repositioned flap, type of bevel used, and on which all sites these two are indicated. A reverse bevel incision is made in the attached gingiva in the apically repositioned flap. You can see here in picture 1, a reverse bevel incision is being made. Okay. It is angled to excise the periodontal pocket in a scalloped outline with a vertical relieving incisions at either end. A split thickness flap is made down to the bone and then converted to full thickness, leaving a residual collar of tissue around the root surfaces. This combination of pocket epithelium and granulation tissue is removed with curette. If indicated, the alveolar crest can be remodeled. The flaps are displaced apically and then sutured. This is the difference between modified Widman and apically repositioned. Their flaps are sutured back to its original position, but here flaps are moved little apically and then they are sutured back. In this procedure, osseous surgeries can also be performed during the phase 3. Whenever the tissue enclosing pocket is being discarded, flap is elevated, pockets are excised, and same time any osseous surgeries can also be performed. It includes exposure of the alveolar bone, exposure of furcation area, minimal post-operative pain, pocket depth, ability to reposition the flap, and primary closure of the wound, and keratinized gingiva is preserved. This is being the main advantage of using this flap. The disadvantage, it includes exposure of the root surface, leading to the increased susceptibility to caries and sensitivity, and loss of alveolar bone height, which accompanies full exposure of the bone at operation. So what are the osseous surgeries? It includes bone recontouring. It has become less popular as it is always accompanied by some degree of alveolar resorption and therefore decreased support to the teeth. What is alveoloplasty? It is a conservative recontouring of the bony margin that is non-supporting bone usually. Ostectomy is excision of the bone aimed at eliminating intra-alveolar pocketing, but unfortunately it decreases the alveolar support. The aim of osseous surgery should be to establish a more anatomically correct relationship between bone and tooth while maintaining as much alveolar support as possible. So this should be the main aim. Depending on the aim, you can select the type of osseous surgery. Other flap procedures include simple replaced flaps which give bony access compared to modified Widman flap. Also in case of crown blending procedures, which can range from a simple gingivectomy to an apically repositioned flap with or without the removal of the bone. Gingivectomy, it is indicated whenever there is a persistent deep supraalveolar pockets, gingival hypertrophy, their reshaping severely damaged gingiva into an easily manageable contour, and to treat gingival overgrowths. In this procedure, pockets can be delineated by use of pocket marking forceps such as Crane Kaplan forceps are used. Marking out the line of incision, either smooth or scalloped, is made with the blade angled at usually 100 to 110 degree to the long axis of the tooth. This beveled incision excises supragingival pockets and allows for gingival recontouring. One of the incision has been made, the strip of gingiva remaining is released by an interclavicular incision. The root surfaces are then curated and an open area of freshly cut granulation tissue left to heal under a periodontal pack for about 1 week is given. Chlorhexidine mouthwash 10 ml for twice a day for 1 week it is also recommended. Excuse me. The drawbacks being it is not suitable for the management of deep true pockets, as excision of the pocket will remove the entire thickness of the keratinized gingiva and possibly disrupt the biological width. It is of no value in treatment of intrabony lesions. These include loss of attached gingiva, raw wound, and exposed root surfaces. Some remodeling of alveolar bone occurs despite there being no operative interference. Periodontal surgery for the regenerative techniques. It mainly includes the guided tissue regeneration, the recognition that epithelium migrated along the root surface before any other cell type after periodontal surgery and created the long junctional epithelium, which prevented new attachment, created the possibility that prevention of migration of epithelium would allow new creative tissue attachment. In the first reported case in 1892, Nyman placed a barrier membrane in the pocket of a tooth that was planned for extraction. Through this method, he came that there is a tissue regeneration procedure, or it occurs. So what he found histologically? The analysis of the tooth after the extraction showed that the barrier membrane prevented apical migration of the epithelium, and it shows the signs of true regeneration. What is a true regeneration? A whole new cementum, periodontal ligament, and a bone was formed. It can only be determined by histological analysis. This is being the drawback of this, and not possible in real life access, such as unless you extract the tooth, which could in effect defeat the purpose of the periodontal surgery. Therefore, how to confirm or how to assess there is a epithelial attachment is formed for the confirmation. So few surrogate measures such as radiographic evidence of bony infill are used to assess the success of any regenerative procedures. Guided tissue regeneration is essentially interposing a barrier to epithelial migration prior to completion of surgical or non-surgical therapy. Original barriers were non-resorbable. More recently, resorbable membranes have been developed, such as BioGuide. These eliminate the need for the second stage surgery. So these are being resorbable, they just get resorbed there. Bioabsorbable flowable polymer has also been developed. This GTR can be used alone or with the bone grafts or the enamel matrix. So bone grafts may be used in combination with the barrier membrane. These grafts can be autogenous grafts, allografts such as demineralized freeze-dried bone, or xenografts such as grafts from inorganic bovine bone matrix, that is from the different species. These are in widespread use. Patients may have some religious, cultural, or personal beliefs that may impact upon the choice of the graft material. Synthetic bone substitutes are also used, such as perioglass in some cases. So the enamel matrix derivatives, amdogain is a product containing porcine enamel matrix derivative proteins in a propylene glycol alginate gel. These are found in Hertwig's epithelial root sheath and induce the root formation in developing tooth. Locally applied enamel matrix protein may help from acellular cementum, the key tissue in the development of a functional periodontium. This is how these two are uh, acted along with the guided tissue regeneration. So when these are indicated, whenever there are 3-walled bony defects or grade 1 furcations, it is also useful for the treatment of 2 or 3-walled intra-bony defects with furcation. 3-walled defects have a better chance of regeneration when compared to the 2-walled defects, but 2-wall defects also have a better results in compared to the 1-wall defect. I hope you all are aware what are the 1, 2 and 3-wall defects, bony defects. Horizontal defects are very unpredictable and the chance of regeneration are very poor. Grade 1 furcation defects have a greater predictability compared to the grade 2 defects. Regeneration in grade 3 area is very poor. The shape and depth of 3-wall defect also determines the predictability. Narrower and the deeper defects have a better predictability compared to the shallower and the wider effects. There is limited use in generation of new bone for implant placement. Good oral hygiene is essential. Smoking has an adverse effect. It requires careful and meticulous surgical technique. Mucogingival surgery. It encompasses those techniques aimed at the correction of local gingival defects, where all it is indicated, where a change in the morphology of the gingival margin would improve plaque control, such as the presence of high frenal attachments or deep areas of recession. Areas where recession creates root sensitivity or aesthetic problems, a very thin layer of attached gingiva overlaying a tooth which is to be moved orthodontically. Gingival recession. The two commonest causes are plaque-induced gingival inflammation and toothbrush trauma, revealing dehiscence in alveolar bone. Therefore, basic periodontal care and correction of faulty toothbrushing techniques are the first line of treatment. While anatomical features may contribute, these and trauma from occlusion, high frenal attachments, impingement from restorations are secondary considerations. The most commonly used classification system for the gingival recession is the Miller's classification, which looks at the recession defects and the interproximal attachment levels. So the mucogingival surgery is subdivided into mainly based on the free grafts and the pedicle grafts. Free grafts are completely removed from their donor area. Then free gingival grafts commonly on the palatal mucosa and connective tissue are taken and grafted to the donor site, prepared by incising between the attached and alveolar mucosa. A template may be used to harvest the correct amount of tissue. Mucoperiosteum is exposed at the recipient site and the harvested tissue is sutured carefully over this. Free grafts are commonly thicker and normally retain the color of the donor area. A subepithelial connective tissue graft from the palate gives a better aesthetic result. At the recipient site, it is covered by coronally advanced flap. Pedicle graft, these are not separated from their blood supply. Commonly used pedicle grafts are laterally repositioned flap, coronally repositioned flap, and double papilla flap. These are the types of the pedicle grafts. The techniques may be of some value in very narrow areas of isolated gingival recession. Technically, of course, these are flaps but not the grafts. Furcation involvement. The extension of the periodontal disease into the bi or trifurcation of the multi-rooted teeth is known as the furcation involvement. This is established by probing into the furcation or also by the radiographs. We can diagnose it. The possibility of pulpal pathology is increased in teeth with furcation involvement, and sensibility testing is essential. Radiographs give a guide to the degree of alveolar bone loss both mesially and distally and in the furcation area. So it can be classified as class 1, 2 and 3. When class 1 is when probe can be inserted with less than 3 mm distance between the roots, requires scaling and root planing, possibly with furcation plasty. Class 2 being the horizontal probing depth exceeding 3 mm but not extending fully through the width of the furcation area. Guided tissue regeneration together with graft materials and enamel matrix can also be used to treat class 2 furcations. Class 3, horizontal through and through destruction in the furcation area. It requires tunnel preparation or root resection or extraction. Guided tissue regeneration is less predictable with class 3 defects. So you should remember what is class 1, what is class 2 and 3, what happens, how much is the probing depth or the distance in these, and what are the treatment modalities performed in various classes. Treatment usually involves the scaling and root debridement. The scaling and root surface debridement, unless the post-treatment morphology can be kept clean by the patient, it will not be successful. Furcation plasty, an open procedure, it involves a mucoperiosteal flap to allow root debridement and scaling, followed by removal of tooth structure in the furcation area to achieve a widened entrance to give access to cleaning. Osseous recontouring may be used if indicated. So any modifications in the bone also can be performed during this procedure. Flap is repositioned and sutured to increase access post-operatively. There is an obvious risk of pulpal damage, and post-operative dentine sensitivity are also chances of causing caries, which further leads to caries. Tunnel preparation, it is similar procedure to furcation plasty using buccal and lingual flaps, but the main difference being that the entire furcation area is exposed in this tunnel preparation. Flaps are sutured together intraradicularly to leave a large exposed furcation. High risk of post-operative caries, dentine sensitivity, pulpal exposure, making this method to be used with caution. These are being the drawbacks of tunnel preparation. Most value for mandibular molars in patients with optimal oral hygiene. Many cases considered for furcation plasty or tunneling, it may be more sensible to proceed or to more radical approach such as root resection. Whereas root resection involves amputation of one or more of the roots of a multi-rooted tooth, leaving the crown and the root stem. It is important to ensure that the root to be retained can be treated endodontically, is in sound periodontal state, with a good bony support, is restorable, and will be a viable tooth in the long term. These all factors should be taken into consideration before performing the root resection. If it meets the demands of these criteria, then only it can be performed. At operation, it is wise to raise a flap to enable direct visualization of the root surface, resection of the roots with high-speed burr, followed by smoothing, recontouring, and restoration of the residual pulp cavity. Sometimes not possible to proceed with root resection despite apparently favorable radiographs, especially in maxillary molars. So patient should be warned preoperatively. In hemisection, dividing lower molars into two halves is done usually. Two smaller units, each with the single root, is performed. One is extracted and other is retained. Again, root canal treatment is necessary pre-operatively and resection of the divided crown is required post-operatively. In case of extraction, it ensures removal of periodontal disease but carries its own problems like again the replacement for so replacement of the extraction tooth is usually required. Guided tissue regeneration I have already discussed, and even enamel matrix derivatives. Occlusion and splinting. Whenever there is a tooth mobility, it may be the simply result of the periodontal loss of attachment and the bony support. Also result purely as a localized effect due to heavy occlusal loading, causing a widening of the periodontal membrane space. Though this is usually iatrogenic in origin, it is now felt that the diagnosis of occlusal trauma should only be made where progressive increased tooth mobility is observed. But in order to do this, it is necessary to have an objective method of measuring tooth mobility. So the mobility index being grade 1, 2 and 3, when mobility is less than 1 millimeter buccolingually, it is grade 1. Around 1 to 2 millimeter buccolingually, it is grade 2. Mobility more than 2 millimeter buccolingually or vertical mobility, it is grade 3. Priority should be to diagnose and treat any existing periodontal disease and correct any pre-existing iatrogenic cases such as poor crowns or bridges, high restorations. If tooth mobility persists as a direct result of diagnosable occlusal trauma, occlusal adjustment is a sensible treatment modality. If the tooth is mobile as a result of lack of alveolar bone support, this is not automatically an indication for splinting. Splinting is indicated in the following situations where the tooth with a healthy but decreased periodontium where mobility is progressive, tooth with increased mobility with patient finds uncomfortable during function. It is very easy to design the splints which are impossible for the patient to keep clean as all additions to the natural tooth surface will increase the plaque retention. A wide range of different techniques and materials have been described including orthodontic wire fastened to teeth by resin composite alone, fixed bridges, partial prosthesis, acid etch retained splints, and more recently, fiber reinforced resin composite splintings are available. So depending on the case, these splinting modalities are used. Peri-implant mucositis and peri-implantitis. Following the implant placement and connection of the transmucosal abutment, a soft tissue cuff develops around the implants. It is attached to the implants via epithelial zone of about 2 mm in depth. There is an underlying connective tissue layer of about 1.5 mm. The fibers in this layer run parallel to the implant surface and do not attach directly to the implant, which leads to plaque formation around the implant and leads to inflammation of the periodontal tissues. This is called as the peri-implant mucositis, but which is reversible. If the inflammation spreads to the supporting tissues, it is called as the peri-implantitis. It can lead to bone loss and increased probing depths. Crater-like defects in and around the bone can be seen on a radiograph. If bone loss progresses, implants can become mobile. So, implant salvage in the failing stage consists of entire arsenal of the periodontal therapies. Local antibiotics and bone supplemented guided tissue regeneration may be particularly useful in such conditions. Tissue transformation using bone morphogenic protein may also prove useful in future. Implant surfaces can be easily damaged, so plastic or carbon fiber scaling instruments are used while performing the scaling around the implants. Supportive periodontal therapy. Once the adequate treatment is being performed, so a regular follow-up with the patient to keep an eye on the success of the treatment, whether the target is being achieved or no, whether the tissues have reverted back to the healthy condition. Regular checkups or the follow-ups are mandatory. Always the success of the treatment is characterized by reduction in bleeding on probing and brushing or flossing, reduction in probing pocket depths, and change in gingival contour. Once the corrective phase is complete, a program of supportive therapy begins. To avoid further attachment loss and to maintain the therapeutic benefits, long-term patients require monitoring and sometimes treatment to support their own home care. Maintenance visits will involve re-evaluation of plaque control, bleeding on probing, pus and furcation lesions. Radiographs can be taken if required. The first 6 months after the completion of corrective treatment and the regular professional tooth cleaning should take place. Then maintenance visits begin 3 to 4 monthly intervals and lengthened up to 6 months. This is the criteria how the follow-up is usually planned after the periodontal surgery. Although there is a good evidence for the ideal frequency of maintenance visits. Various aspects such as plaque control, bleeding on probing, and alveolar bone heights are considered and frequency decided accordingly. It might vary depending on every patient, and the response to the periodontal surgery by every patient also varies. So the follow-up periods or the intervals has to be planned accordingly. So this is all about the surgical part of the periodontology. Next session will be dealing with some other topic, which I will decide shortly and announce it. Thank you for being a very wonderful audience. I would like to conclude by saying all things are difficult, therefore, before they are easy. CM Dental Academy is always there to help you in your MFDS journey. Any doubts, queries, feel free to discuss them in free Telegram group. Happy studying. I would appreciate your feedback. Thank you.